Right, the surface is.
Okay. Good morning, everybody. Good morning, members of the public and those members online and officers. As you probably all know now, I'm the chair of the Scrutiny Committee, Councillor Jill Slocum. The agenda pack with papers is available via the ModGov or directly from the council's website from the link which was sent out to members. So I hope you've all got everything you need. In line with the recommended meeting procedures, I'm requesting that all members and officers turn off the microphones, videos. Please remember to turn on your microphones and videos when you speak only. This helps the background noise, call quality, and anything disrupting the meeting. When I invite anybody to speak, could you clearly state who you are for the benefit of anybody who is listening and to the meeting so they can identify who is speaking. Please, can I also remind committee members to use the chat function solely for committee business. Otherwise, it can be a bit distracting to those questions and conversations that are happening. Can I warmly welcome you all to the meeting, public, media, and anyone who is joining us today. Finally, as agendas are now viewed electronically, can I request that members and officers refer to page numbers from the published agenda pack to assist all present in finding the appropriate information. I also apologise that there are no nameplates in front of you, so I'm getting to know you all, so forgive me if I don't quite get that right, but I hope I will. And now over to Jamie Jackson.
Thank you, Chair. Just to make another apology to the committee, at the last meeting we agreed that we would have a workshop, an informal workshop after the close of the formal meeting today. That wasn't put within the agenda, so I'm sort of notifying members now that, having discussed with the chair this morning, the intention is that we will try and complete the three main committee items, sort of formal agenda items, by 12 o'clock. And then we will complete the hours workshop between 12 and 1, and then members will be away at that 3-hour mark, which is what hopefully all members were intending to stay for. Anyway, I am aware that there is a funeral that several of you will probably want to be getting away for, but if we can try and sort of be done by 12 for the informal session that Emily will be leading on, and then we can have a good hours workshop, and then everyone will be away by 1. Thank you, Chair.
I hope everyone's happy with that. Councillor.
Just clarification, is that part of a scheduled meeting? I mean, it would help me if I can leave before the workshop, but I mean, I'm required to be here for core reasons.
Not for the workshop, Councillor.
Thank you.
Identify who is able to stay for the workshop. So I know some of you also got extra meetings. So there is only 3 councillors and 4 councillors. So is that okay?
It's up to Emily, really.
Emily, what do you think? Because I apologise, Emily.
It's a workshop or a consultation really surrounding the learning disability and autism strategy, the ICS strategy. It'd be brilliant. We need to get members' views on it and to consult with people, very much getting views from your constituents as well. So it's really important. I think even if we've got 4, I think we may not take an hour then in terms of doing that, but it's a really important topic that we do need to discuss.
I do apologise that for some reason we haven't got we've got a lot of people online. It's a lot of it overlapping of meetings, and I do apologise, but anyone that's on this committee, we always hope that they will be actually present. So I do apologise. A lot of work's gone into these things, so very sorry. Okay, item 1 is apologies for absence.
Thank you, Chair. So we have apologies from Tony Robbins, who sent a sub, Councillor Martin Lovell, Christine Lawrence sent a sub, Councillor Martin Whale, Hilary Bruce sent a sub, Kathy Pearce, and apologies from Councillor John Bailey and Councillor Graham Oakes.
Can I thank the subs for coming today? It's really very much appreciated. Thank you. Item 2 is minutes of the meeting held on the 12th of September, pages 7 to 12. Can I have your agreement that this is a true record and you're happy with the minutes? Everybody in favour? Could you please identify?
My question.
Okay, yeah, Councillor.
I was here something last time, and when the NHS lady from the NHS was questioned about 106 and whether or not they were ever asked to take part in the procedure to build I don't know, health centres, etc. And she said very rarely, if ever. And I just thought that was, for the council, a really, really telling point. And I had read the minutes, but I couldn't find it in there. I don't know whether it should be in there or not, Chairman, but
We can amend them.
We will amend them to actually add that point, because it is a good point. And in actual fact, I've also done some ferreting on that thing, and it's not quite as was said. So I have to say, I think you'll find that sometimes when developments go in, there are often opportunities for there to have some NHS importance in there. So it's not always as it was seemed. So thank you for that. Right. Item 3 is declarations of interest. Do we have any? None. Item 4 is public question time.
Chair, we have had a public question submitted by a regular attender to our council meetings, Eva Brashowski. I think Eva was hoping to either join us in person or online. I can't see her on either at the moment. As it relates to item 7 on the agenda, my suggestion is that we keep it back. If Eva is then present with us before item 7, then she gets the opportunity to read it then. If not, then I'll read it out to the committee, because I think possibly the officers who are responding or presenting the dentistry item aren't online either yet. So
that seems very sensible. Okay, thank you very much for that. Okay, we've got a 4A, which is the work programme. Now, you have a hard copy in front of you on the new work programme. As you can appreciate, this is often updated when new items come into play. So that's why you've got the hard copy. Do I have any comments, please, from anyone? Jenny? Oh, sorry.
Sorry. Yes, that's a.
I believe that there was going to be a further discussion and update on dentistry. I know we've got one today, but it's very, very minor and it doesn't really give us very much. At least from what I can tell in the papers, but I'm sure that we discussed further information early next year.
if I respond to that, Chair,
Thank you.
I think, to be honest, Councillor, that this is the opportunity today at that item to really specify what it is you want within the dentistry, because I appreciate it's taken a long time for this item to come to the committee, and it's taken quite a lot of perseverance from our side to get it here. So I think this is the opportunity for the committee to really nail down what it is they want, and and a realistic expectation from colleagues as to when they will be able to provide that information to us.
Lovely, thank you very much.
Thank you. Okay, thank you. Can I go to, oh, sorry, Councillor Woods. Oh, sorry, Councillor Woods.
No, that was my question about dentistry.
Okay, thank you. So just to say, oh, Jenny, I think you need to speak first. Jenny, do you need to speak first? No? No, okay. Just to say that the 5th of December meeting, as you can see, there is a joint meeting with the Children's and Families. 25th of October, sorry, 25th of October, so I jumped the line. But on the 5th of December, you can see we have obviously the budget, obviously the update of the mental health response, prevention strategy, stroke service consultation, that's the results, and the crime and disorder report. So it's a packed agenda for December. So I do hope, as I can say, that we need to get as many members here present, because I think every meeting is important, but that's a really good one. Don't worry, there will be, there can be, I don't like to say slippages, movements. Did you want to say something?
Sorry, I was just trying the people doing the dental
Presentation.
You use your microphone. I'm so sorry, I can't hear you.
like the people doing the dental presentation later have already joined us. So I didn't know if we keep on picking up dental, whether it's worth them coming in to join us. They're at the front. I don't know if that was useful or not, but I thought I would suggest.
They're
already, you can see them. You can see them. Is that what you're saying?
well, I think we'll just take that when we get to the item.
Yeah, we'll take that when we get to the item. All right, so don't worry. But thank you very much. Always helpful. Normally the reception let us know, and it all works really seamlessly. Okay, so lovely. Okay, so I'm now going to move on to item 5, which is the adult social care report and the winter planning. And I would like to invite Mel Locke and Sheila Meldrum to.
No, Chair, Mel's not here today.
No, sorry.
Give her apologies, but we've got John Padfield, but I'll just quickly give you a quick overhaul and then I'll let John go on if that's okay with you, Chair.
Wonderful.
Thank you, Chair. The report today provides an update to Scrutiny members on the performance issues with performance within adult social care. You will see from the report today, we receive over 5,000 calls monthly through Somerset Direct, who resolve a significant number of our inquiries without involving our statutory duties, taking pressure off our social care teams. You will also be aware of our care assessments and reviews, which remain high, but we have put measures in place to reduce this backlog. And you will see this from this report. We have put additional investment into home care provision to significantly reduce the level of unmet care home needs to their lowest since 2021. I think that's a massive achievement for our team. However, we have seen a number of care home closures in recent months, which leads to concerns on capacity in providing extra care support to the residents and their family. This is putting pressure on our services. You will also see from the figures for discharge to pathways, 94% of over 65-year-olds were discharged from hospital and returned home, with over 80% able to return home with no formal support. Again, I think that's a measure of our success in this area. What is really encouraging is the news that our stakeholders feedback, which shows an overall rating of good or excellent, and it shows an excellent work the dedicated staff are doing for our residents. And I'm happy to hand over to John. Thank you.
Thank you very much, John.
Thank you, Dean. I'll talk through these slides. Jamie, are you okay to work through the slides? Dean's picked up some of what I'm going to talk about, so I'll go into a little bit more detail, and I'll pause after each one to take any questions. For the first one, what we call front door demand. So this is the volume of people that are contacting our front door in relation to adult social care, asking for help and advice. The numbers have remained fairly sort of stable, well above 5,000 per month. But what we're seeing, so that's in the line chart at the top, what we're seeing in the bar chart is that the resolution rate, so proportion of those calls that Somerset Direct are able to resolve with no need to refer to adult social care, no costed service, is actually starting to just dip. We've been 2 months below our target of 60%, still in the high 50s, 59 and a bit percent. But that's a concern, and I think it's potentially a sort of proxy indicator for the complexity of those calls that we're seeing. And then following on from that, and also, so after Somerset Direct have triaged those calls, the ones that they're not able to resolve come through to adult social care and become either care act assessments and then potentially reviews. And what these two charts show is the pressure in those two areas. So the number of overdue care act assessments, which is increasing, number of overdue reviews, which is also increasing. And there are a whole variety of issues there, including workforce pressures. There's actually a piece of work that we're involved in at the moment where we're looking across the region with other councils in the southwest to understand what that looks like for other councils. Somerset are actually doing some analysis across the region on behalf of the Southwest Association of Directors of Adult Social Services. Very high level findings at the moment, but what it shows us is that we're not really an outlier, which is, there's no real comfort in that, but it does show that this is an issue that lots of authorities are facing. Okay, unmet needs. So we call this unmet needs. So this is where we've identified, following an assessment, that somebody requires a package of home care, but where we're not able to source that from the market. And if we go back to, I think it was August where we reached the peak, we were well over 100 people where we were unable to source care. Some of those people waited for quite a significant amount of time. If you look back at the last couple of months, so to the right-hand side of the chart, we're in the low single figures. We've had a couple of months where we've been actually at zero, so there's been nobody waiting. At the end of August, there were 4 people waiting. So that position has improved significantly, and that's a reflection of some of the investment that we've put into the domiciliary care market. Picking up that kind of complexity thing again, what this chart shows is quite simplistic, but if we look at the average package size, so the average number of hours per week of a domiciliary care package that we're being asked to find following a Care Act assessment. In 2020-21, that was just over 10.5 hours a week. So far in 23-24, it's up just over 14 hours a week. So that's a increase of nearly a third. And that again is just an indicator of the relative complexity of the people that we're supporting. And in this one, this is the Care Quality Commission who inspect our providers, both residential and nursing homes and domiciliary care providers. And actually we're seeing a decline in the proportion of our providers that are rated as good or outstanding. So in August, just over 81.5%. That's worth noting. I know there's a lot of text on that slide, but the key bit is that at the moment, the Care Quality Commission are using a risk-based approach. So they're looking at potentially the highest risk providers, so maybe where there have been concerns raised, etc. And we think that has a correlation then with the reducing number that we're seeing that are being rated as good or outstanding, because there are providers, let's say, that have had existing issues raised or maybe are struggling. There's a new inspection framework coming into place next month. So hopefully we'll start to see that position stabilise and maybe even increase. On dom care again, domiciliary care again. Good news here. We saw a real spike in the number of what we refer to as package handbacks. So where providers tell us they're unable to continue to provide domiciliary care to a service user. So in 2021, there were 233. That increased in 2022 to 238. What the top chart there on the right-hand side shows is that those numbers are reducing. And I think we accept that it's inevitable that there will always be some package handbacks. But in May, I think it was May 22, we had nearly 40 in a month. And that provides some real challenges in terms of sourcing new packages for those people going back out to the market. So seeing that declining is a definite positive.
Can I just ask a question? You talked about the handbags, but is that because people don't need the care anymore, or do they need different care? I didn't quite understand the detail.
So they still require care, absolutely, they still need the care. And there are a variety of reasons why the providers may hand them back. So sometimes it's to do with their capacity, so their workforce. Sometimes it's to do with the behaviour of the service user or the service user's family sometimes. So a variety of reasons, but in over 50% of cases, it's to do with the workforce capacity of the providers.
Right. There are also people included in that whereby they're paying for care privately and then come into our market, or is that a different?
No, so these are entirely people where
That are already in our.
Okay, yeah, so they're already in funded care.
Thank you. Carry on, please.
So intermediate care flow. So the 94 and a bit % that was mentioned earlier, you can see at the bottom of that chart. And what that shows is that we're getting the vast majority of people age 65 plus that are being discharged from hospital, home, or to their normal place of residence. Really strong performance. 86% of those have gone home or to their normal place of residence with no additional support. The difference between the two figures are people going through our intermediate care system, so either into discharge to assess where they're going home with some additional support, or into one of our pathway beds where they're receiving some reablement rehabilitation support before hopefully moving home.
I just want to, I'll come back to you, Councillor. But that does worry me a lot, and I think it worries a lot of us, that we want people to be home. We want people to come out of hospital, not going to nursing home, being able to go home. But it does concern me that are they getting the correct care they need? It's all very well sending people home, which is wonderful, but we must be ensured that they are getting the right care, essential care. Can you confirm that that is happening?
So one of our statutory measures looks at the proportion of people, it's a bit of a technical measure, but it looks at the proportion of people that were still at home 91 days after being discharged from hospital and having gone through intermediate care. And our figures for that are in the high 70s to 80%. We haven't had the most recent data published yet, it'll be published in November. So in 70–80% of cases, those people have remained at home, which suggests the right level of support has been there. In some cases, they have been readmitted to hospital or they've moved into residential or nursing home. But that's in a 3-month period following that discharge from hospital.
I think it would be good for us to have an update of that data, please, because it's really important. Okay, thank you.
So for the December meeting, we'll have that national data set will have been published,
Yeah.
and there's a performance update on the agenda, so we can bring it back here.
That's very kind. Councillor Woods.
Thank you for your report. Going right back to when you phone up and you want some help, I'm pleased, in a way pleased, I'm not pleased, but that the numbers are so high, because I had cause to call the line, the county line, and say I want adult social care. I was then held, I got one answer, then I got another, and I thought I'd been given the runaround, but it seems that the numbers are there and I had an answer in the end, but the care that I need hasn't yet been forthcoming. And I say I've had a run round where I've had to talk to the community workers, I've had to talk to the home, I've had to talk, and that's my job, I suppose. But I did feel that I've been given the runaround, but obviously the numbers are so high that you're to be congratulated on the number you're coping with. And the initial one was quite good. In fact, the first 2 initial calls were quite good. And I've ended up at a dead end at the moment with a 95-year-old needing care soon, which we haven't solved yet, but I'm hoping that it will happen, because my ward, my division, and the West Somerset generally, we have a high proportion of aged people that perhaps come out from strokes, and then they have a break, and then they come back into care, and it's those ones that I think we're having trouble with. All right, but thank you for your report.
Thank you, Councillor.
Thanks, Jill. Just a quick one on the immediate care flow. There is a disparity of 7.5%. And I'm just wondering if there's any possibility of a breakdown.
Excuse me, councillors, can we just have one meeting?
Sorry,
Thank you. Sorry.
So there's a disparity of the 7.5%. And I was wondering if it's possible to have a breakdown of how many go back into hospital, whether they should have been discharged from hospital, and who's financially responsible for that? Is it the NHS for discharging them too soon when they still needed care? Because that's going to be incredibly costly on us when it isn't necessarily our responsibility. Because they just obviously want to clear people from beds. So is there any way that any work can be done on that, please? Because it may be quite costly to us.
Yeah, so we can absolutely look at the outcomes from, so when somebody goes on to what we call pathway 1 discharge to assess, we can look at the outcome from that. So did they go on to receive extra care and support, domiciliary care? Did they go back into hospital? Did they go into residential nursing care? So we can do some analysis of those outcomes, and the same for the bedded pathways. In terms of the question about being discharged too soon, I mean, those discharge decisions are multidisciplinary. So adult social care are around the table with clinicians as well. So it's not that health are pushing people out and we're just having to accept them. We're part of that decision-making process.
Yeah, that's all. Thank you.
Thank you.
Okay, so stakeholder feedback. So we know that we need to get more feedback from service users, but where service users do contact us and provide feedback, positive or negative, what we're seeing is that in the last 12 months, 85% of the responses that we received rated their overall service as good or excellent. So that's really positive. We'd love that to be 100%. But you know, inevitably there are some complaints in there where we didn't get things quite right. But I think 85% is a really, really positive figure. And then the final slide is just a little overview of some of the work that's going on at the moment with Newton Europe. So we're working on the My Life, My Future programme. One of the kind of key strands that I'm involved with there is around data visibility and control. So that's about making sure that the whole workforce have access to data, understand what the data is telling them, can use the data to help them to make decisions and to plan. And that we understand the impact of this transformation programme across adult social care as well. Any questions?
Councillor Pearce.
Thank you, Chair. Yeah, my question is regarding sort of discharge from hospital. You know, we're always hearing about the NHS struggling because there are people who are unable to move on and therefore causing a bit of a blockage. And yet the figures seem quite high here. And it's really good to see the unmet need has reduced. So just a question really about sort of the disparity. It's seeming the numbers of discharge with, you know, care at home seems to have increased. Has the bed, I don't like calling it bed blocking, but for want of a better term, has that decreased as far as you're aware? And also, just with the closure of the care homes, are we sure that there is capacity, you know, for seasonal changes for those that are in hospital and need to leave or need a care package in a home? And the other thing is, in this presentation, there's nothing mentioned about carers. And with increasing number of people being cared for at home, it places a huge strain upon carers. And I just wonder where the carers fall within this, you know, this scenario, and what is that we don't lose sight of people actually doing a lot of work at home for their loved ones, and some mention of support for them would be good, please.
See if I can remember each of those questions. So we go to the first one. So there's a measure now called no criteria to reside, which used to be what's called delayed transfers of care. So that's people that are in hospital that no longer need to be in hospital and will be discharged. So the slides in the intermediate care flow show those people that have been discharged from hospital, but there are always a number that are in hospital that are categorised as having no criteria to reside. And those numbers have remained, I think, stubbornly high. And sometimes that's about waiting for a package of care, waiting for an assessment from adult social care. So we're working closely with the acute hospitals to make sure that we can prioritise those people and help to move them out of hospital, especially if they don't need to be there. Sorry, remind me of the second question.
It was about, with the care home closures, are we sure there is capacity, especially during the winter months when I would imagine the demand is higher?
Yeah, so Paul, Emily's counterpart on the commissioning side, is doing lots of work with our care providers to ensure that we do have that capacity. And we're also, not just for winter, we're looking, you know, beyond that into the next years and even decades to try and establish what our demand is likely to look like. So I think we're confident at the moment that we've got the capacity we need. Increased levels of complexity, we're probably going to need more in terms of support in years to come. And then the carers question. Yeah, so the survey that I mentioned earlier that we've done across the Southwest, an aspect of that has looked at carers assessments and carers reviews to understand, is it a case that we're not completing those assessments, they're outstanding. So we can bring some analysis of that back to a future meeting. We're also about to undertake the next carers survey. So every 2 years, we do a survey, a statutory survey of carers. Those surveys are about to go out. It's unfortunate because by the time they've gone out and been returned and then the results have been analysed, we don't actually see the results until later next year. But the previous survey was nearly 2 years ago, so they're a bit out of date. But in future, we can absolutely bring some data around carers to one of these meetings.
Can I just come back on that? Thank you. That would be really, really useful. What is the criteria for being classed as a carer? I ask this because I've been through a situation myself, and that whilst I wasn't receiving receipt of carers allowance, my mother was in receipt of attendance allowance, and I was her primary carer, and I wasn't aware. I didn't have any direct contact with the council around that, but you know, there were people who were being stretched to their limits with all good intention, but not being in receipt of the carers allowance. It was just, is there a mechanism for picking up people who they are caring for, who will be on attendance allowance, but not carers allowance? I only ask that because the numbers are going to be increasing, I'm sure, and a lot of responsibility is placed upon those people.
I'll defer to Emily for that, and you can give the carer answer.
So there's a slight difference between the carers allowance, which will come from the DWP, which will have its own sort of criteria in terms of that. But from a carers assessment point of view under the Care Act, the threshold is really quite high. It's the outcome that happens afterwards, and it really, what we still use in terms of the Care Act eligibility is slightly different for somebody with care and support needs individually. It's a slightly different eligibility framework, and then the outcomes, it's much more important about looking after or supporting individual well-being. But the two don't necessarily, just because individuals would have a Care Act assessment doesn't mean to say that people would automatically get carers payments, because the two don't equate together.
It's an anomaly, isn't it?
Yes.
It's definitely an anomaly. I have to tell you, I know somebody who was brought to my attention that they were looking at, not you of course, and many years ago, were carers, attendance allowance. The person, they'd been dead for 20 years and they were still getting the money coming in. Now, what worries me is, and it wasn't their fault, do you know what? They were older person, the money was coming in, they didn't even realise, do you know what I mean? So there you go. But what does worry me is that we're stretched for money here. We need to be very careful that these things are tied up. But I thank you for your questions, Councillor Pearce, because when I did this report, I had loads, but I want to first say to people, can I first, in June 2023, Somerset Direct won the Best Transformation Programme and the Southwest Contact Centre Forums Award. So congratulations there. We haven't done that. We should have done that first. So that's a big congratulations. I'm analysing, I had quite a few questions, but you've done a good job. And you've done a good job. You've answered most of them. Most of them may not be maybe the answers we all want. But I think on the analysis of what we've gathered here today, I think overdue assessments, I think that's a prime thing we need to look at. I think the closing of nursing homes now, especially locality-wise, Bridgewater, especially in other places, seems the wrong time of year to close a nursing home or a residential home in the winter. But no doubt somebody has the right answers for that. I think the discharge from hospitals, I think that is a bit of concern for us about, as we clearly said today, making sure the mechanism is in place, people are looked after. So I think that needs to be, and obviously the unmet home care needs. I think that's it's something that needs to be on the table still, because that is whilst it is getting there, it's getting better. And I've always said this, I think once the transition happens, that perhaps people aren't needing to go into residential homes and they can be looked after at home. Once that happens, we will see a marked improvement, hopefully, in our budget and everything else. But there is this transition period. I think it's very, very worrying, very worrying. And we do want everybody discharged from hospital, but I just want to make sure that everyone's cared for when they get home. So does anybody think I've missed anything out? Councillor.
Oh, good. A small question and a bit of a statement, really. Put that on. It's quite an encouraging report, Chairman. I think I was surprised by it, and well done. Just a small point on overdue care assessment. The two graphs, is the top one meant to be 22? I can't see the point of the two graphs otherwise. Just
pages,
The,
what
the
page?
top one is care assessments, the
Oh,
chart
right.
is reviews.
Thank you very much, Al. Good. Thanks for explaining that. And the only other, Chairman, is that, it strikes me from hearing one or two of the questions that us councillors only hear about the difficult cases, I suspect. And we think, oh heavens, what are we going to do and how are we going to do it? And we're slightly tainted almost in our approach to this subject because we get all the sticky ones, and I'm very glad to see the figures, and I hope that those sticky ones will now, because you're improving on the performance here, though our experiences will be better on that. Thank you.
I'm just going to say that's an excellent deliberation on this report. Thank you, but certainly.
I think you're right. I think a lot of us around the table today only hear about some of the more challenging issues. And that's where it's so important to really get the feedback from family members and from individuals, and to have that 84% of people feeling really satisfied with their care. We do publish that in our highlight report, the adult social care highlight report that goes out every month. And we publish exactly what people have said. So I'd encourage everybody to look at that and read that, because it does fill your heart a little bit, really.
Thank you, Chair.
And I do also think, as a scrutiny role, you tend to be scrutinising negativity. You're not necessarily going to be scrutinised, so we all pat you on the back. And there's a sort of a dilemma there. But I think, as I set out, to suggest further actions really are, as what I've said. Are you happy with them? How I raised those? Are you happy? So I just wanted you to be clear about the further actions that we all agree. Councillor.
Thank you, Chair. Just to let you know that I've actually been around and visited most of our care teams, and I can tell you the Somerset Direct actually has a massive benefit to our social care workers. The amount of information they gather, the amount of time it saves them is unbelievable, and they really appreciate it. And actually Somerset Direct got some really good people. I appreciate we've had a bit of an issue on one of the. Also, we mentioned care homes closures. Paul and myself have been really active on looking at a plan to we obviously want to keep people in their homes, but obviously we've got to look to the future. If you saw the public health map the other day, and you see the growth of Somerset, it was very frightening, the situation we're going into. It was really worth you getting those slides. They're absolutely frightening, mind-blowing, actually. I was nearly hid. But just to let you know, we are on it. We have spoken to some providers. We've got a care home now that's closed. We're looking to see whether we can bring that back in. We don't know yet. We're doing all sorts of things we can to resolve this. And I only wish I was doing this 3 years ago, because I think we'd be 3 years closer to, no disrespect, I'm not trying to, I can see that we need to get this sorted out, as Paul said. So we are on it. I assure you, I don't speak that much very often, but I am really, I'm trying to get my head around it and get on it.
Right, thank you for Councillor Ruddle. It's good to know that our portfolio holder is earning his bread. We don't want anyone not doing anything, so thank you for that. I think we now need to talk about the future, the here and now and the future, and that's my life, my future. And that's what we need to have in our minds, and those 5 areas, vitally important. So thank you for your report today. If there's no one else got to, just thank you for coming today. Like I said, I had a lavish load of questions, and you've answered it, so well done to you. But congratulations again to Somerset Direct. I think that has to be minuted, and I think we all agree it's so good as a scrutiny when we can pick out the positives. So thank you very much. Okay, now we go to item 6. Is the Integrated Care Forward Performance Plan, which is page 41 to 50. And I invite Alison Henley to introduce this report, please.
Thank you.
What's that?
Sorry, Chair, what happened to the budget report?
Well, I have a
Page 29.
Page
I have
29.
mine. I've done the work, but I haven't got it on my agenda, so sorry. So can we just do the integrated one at the moment? We'll talk about the budget in a second, all right? Can we do that? Is that all right? Just carry on, Alison. Thank you.
Thank you. I can't profess to be able to do the budget report if that's okay. There's a report in your pack, so I was just going to talk through it for a few minutes and then come back with any questions. Before I start, I'll introduce myself. I'm Alison Henley. I'm Director of Finance and Director of Performance for the ICB for NHS Somerset. So you've got the report in your pack on pages 41 to 50, and that shows performance for the period to July 23. And that represents our most up-to-date period at the time of writing the report. And it's the same period that actually we considered in our ICB board at our public meeting last week. So I just wanted to pull out a couple of headlines from the report, if that's okay. So I'll try and use page numbers first, but please tell me if my page numbers are wrong. So page number 41, I just wanted to pick out, we've started with access to primary care services. I just wanted to pull out that in July, we saw 4.8% more people in our GP services than the same period in the previous year. Of these, 59% were seen face-to-face, and we've included a detailed overview on how we intend to further improve access to these services, and that was brought to the last Scrutiny Committee on the 12th of September. And we've committed to bringing an upgrade back to a committee towards the end of this financial year. Moving on to page 42, we can see that our 111 services have seen an increase of 20% over the period April to July compared to the previous year. The service indicators on the average speed to answer of the calls and the number of people assessed by a clinician or clinical advisor were in excess of national benchmark performance. But the number of people not waiting for their call to be answered is not where we want it to be. In the report, we've outlined the actions being taken to address this, and mainly regarding recruitment and workforce. If I move on to page 41 to 42, where we start talking about the ambulance service, actually what we can see is there's a slight reduction in the number of people calling the ambulance service, but the number of people needing to be taken to hospital is 10% higher than the previous period. Most times are not where we want them to be, and significant investment has been made into this service in 23-24. And that's to improve the level of frontline resources through increasing our workforce and the number of ambulances available. And again, the further actions are drawn out in the report. On page 44, I've given a brief overview in terms of A&E department, at Musgrove Park Hospital and the overall district hospital. And the number of people going there were lower than July in the previous year, but higher if we compare the cumulative period April to July. We can see the delivery of the 4-hour standard is shown an improved position compared to the previous one. And I just wanted to update the committee, we're also higher than the national average position. Moving on to page 45, the number of people waiting the longest is better than we had planned. And this is measured in the number of people waiting over 104 weeks, of which we have now 78 weeks and 65 weeks. And again, an active programme is ongoing to maximise the number of people receiving treatment, and the report outlines some of the actions being taken by our colleagues in Somerset Foundation Trust. Page 46 talks about our diagnostic testing activity, and again, disappointingly, the number of people waiting for a diagnostic test is increased, but the numbers waiting the longest, as measured by people waiting over 13 weeks, has reduced. The report goes in to say which specialties are waiting the longest, and again, the actions being taken in order to increase capacity within those services to reduce the backlogs. We've moved on to talking about cancer services on page 47. And I just wanted to highlight the 28-day faster diagnostic standard performance is improving, with performance of 73.3% in July, representing a 4.2% improvement on the previous month. The report outlines the actions being taken to increase capacity in psychological therapy services on page 48. And this is through a combination of increasing workforce, external support, and increasing our digital offer to patients. This service continues to exceed the national targets for recovery rates, where Somerset continues to be the top performer nationally. If I move on to 49 and continue our mental health theme, We've continued our investment into services to support mental health of our children and young people within Somerset, and the report outlines what we've achieved within our service. And lastly, in my quick canter through the report on page 50, I just wanted to highlight historically we've seen an increase in the number of people with serious mental illnesses accessing improving health checks, but the performance in the first quarter of this year has now reduced. This continues to be a significant focus for us, and the report details the actions being taken to improve this performance with an emphasis on what can be delivered outside traditional health services. So that was a very quick canter through the report. Hopefully that's useful. I do talk very quickly, apologies, but I'm happy to open it up for any questions or reflections.
Well, thank you very much. It certainly was, but you did it very, very well. Thank you very, very much. Your report is excellent, I have to say. So we all read the report, we've all read it. I would just like to ask a question. I was a little bit concerned about the cancer, the 28-day faster diagnosis. Obviously being in that club as well, with many of us here, it's a good club to be in and you get great service. I thank God that I'm in Somerset. But I just wondered when it says it's better than the operational plan of 64.5 in June. So what is the analysis that what is your level that you want to get to? Because we obviously want 100%, but that's probably not there. But I remember when there was a 13-day, you had to be seen in 13 days, and I had typical, mine had breached, but they ran into absolutely brilliant quickness, you know. But we just want to make sure that our cancer treatment is the best. I think we obviously appear we are better in Somerset. Can you just give me a little bit more analysis on that, please? Give us, sorry.
Yes, of course you can. So cancer standards monitoring is changing, and I can provide an update to the committee. I can't probably do it now if that's okay.
An update would be great.
But what we're doing is we're still focusing on the 28-day faster diagnostics, and that's the standard that people understand in terms of that, plus the 2-week wait. So even though they'll change nothing nationally, we're still focusing on those because that's what our public would expect of us and what we expect of ourselves. And that's what we're trying to achieve for. Where we reference our operational plan every year, to this year. And what I wanted to highlight by bringing out that comment within cancer is we've exceeded what we thought we would do at the beginning of this year. Saying that, the report pulls out a number of areas where actually our performance isn't as good as we'd want it to be, and we have to recognise that and try to bring some of those out. One of the areas particularly that we're working on is the skin cancer services, and that's brought out within the report. And I'm sure a number of people were sat around a table with me several years ago when we had problems with recruitment into our dermatology services within Somerset. And we started using the services at University Hospital, Bristol and Weston. What we're looking at is bringing those services back into Somerset. That was always our intention, is to bring those services, but we recognise there's a national recruitment issues for dermatologists. So if anybody knows a dermatologist, please let us know. But we are looking at how do we do that. So we're committing to bringing people back. We've brought a number of, when I say bringing people back, this means actually we don't need people to travel to Bristol to have their treatment. There will be a service within Somerset for them to access. So we've already looked at actually opening up that service, and what the report starts to reflect is we partially did that in September, but our ambition is to have that service up and running by the autumn. I can't be specific on the date at the moment, and that's why I say we can always come back with some of these because it's depending on the recruitment. That is our ambition, is to bring as many people back. Now that depends on where patients want to go. So some people, it will still be easier to access services in Bristol and Bath, and that's why we'll say it's by patient choice because it's closer to where they live. We're bringing that service back into Somerset that we haven't been able to do historically. So that's part of what's pulling down our cancer performance.
Well, thank you for that. That's very good. I just wanted to say that obviously we want everything in Musgrove, okay? Everything. We want everything in Musgrove because it's a superb. Bristol's quite lovely, but superb. So it's really good to hear about the skin cancer, because obviously, and I have to say, the reports recently has made us all, I've been made much more aware and much more conscious now than we ever were when we were all younger. And you know, so I think it is a good thing for us to have on the agenda. So thank you very much. I think an update on those points that you've raised, I think would be really, really good for us. I think the committee agree. You'd like an update on this. I think that'd be really great, please, because I think it's something we need to keep looking at. How well we're doing with the cancer, how well we're doing with the skin cancer, and obviously the serious mental illness. That's another thing we really need an update on. So thank you very much. But thank you for your report. Thank you. I'm just going to bring the people into the room, and then I'll go to online members. Thank you.
Thank you. Just a few questions, hopefully I'll be quick. You discussed 111 increase in calls. Is that down to being directed by GPs to call 111? Is it not people not being able to get hold of GPs? Is there a reason for that increase, please? The second one is you've got a 10% increase in people being transported to hospital. Are you looking at why that is? Is it again 111? You know, people waiting too long basically and being more poorly and not getting care prior to that, leading them to need to go to hospital. And the other question is there any issues with weekend discharges? Are people ending up staying in hospital slightly longer due to not being discharged over the weekend due to reduced staffing levels or whatever reason? Thank you.
Okay, if I take the first two and I then call on some help for the third one, if that's okay. So 111 calls, we all know there's a national campaign, I think. So we turn our TVs on in the evening and we see 4111. It's one of the recommended areas for our first point of call. So actually a lot of the increase is due to that. So this is people going to the right place at the right time, especially when you haven't got your services open in the evening and you need that immediate response. And that's why it's really important for us to balance the increase in calls with the fact that our call answering service is answering those calls much quicker. We did change our 111 provider. We did change our 111 provider and we are seeing a lot better service response. What's disappointing for us is even when we are answering calls within 20 seconds, what we're seeing is still a high abandonment call rate by people. So this is where somebody calls the number and then hangs up before it's answered. And I don't think we quite understand why. So there's more than we need to understand on that one. What you tend to have then is somebody will continually ring back, so it inflates your numbers of calls as well. So it's a bit of an art rather than science on this one at the moment, but we're trying to work through it because we desperately want people to access services when they need them. But that's probably what's driving some of the increases as opposed to can't get through to other services. In terms of transporting to hospital, what we see, we have a number of services within our ambulance trust. So we have Hear and Treat and See and Treat. So when somebody rings the 999 service, there will be options for them to talk to a clinician, see if that clinician can help them before the crew is dispatched, or also if a crew could be dispatched early to support that patient in their home before they transfer to hospital, because it's not always the right outcome for the patient. We do really well in terms of those indicators, and Somerset does very well. So even though the numbers have gone up, what we can see is that the right people are getting to the right outcomes. So they are going into hospital when they need to go in. They aren't getting turned around. We've looked at trends with in hours, out of hours. Is it because of some of our 111 services? And I think the data is quite inconclusive. There doesn't seem to be one reason or rationale. What we know is when a patient gets to hospital, Somerset has the shortest handover delay. So people aren't waiting in an ambulance for a long time outside Musgrove Park or Yeovil Hospital. They go in and they get the services they need really quickly. And that's a credit to our acute hospitals. We are the lowest in the South West for that. So I am going to answer for you. I know that's not an easy thing to say, but we've looked at all this to understand what's causing some of these, but it doesn't seem to be one trend. It's a number of things that's probably gone on over the last few years, and we can't really pinpoint it to one or the other, which is why the significant investment into the ambulance service this year was really important. So we're working on that workforce. I might not have the answer to your weekend discharge question, so I'm looking at a colleague to my left, if that's okay. Obviously, we'd like more discharges over 7 days. And, you know, we are working with colleagues to make sure that happens, particularly going into this winter period. But I'm going to look to somebody else to answer that question. Would that be okay?
No, that's fine. I can pick up the 7-day discharges. So we do have discharges over a 7-day period through from our acute hospitals into our intermediate care services, be that pathway 1 or be that through bedded facilities, or even in terms of individuals going home with no support at all. We could be better, though. I think there's various different factors. Workforce is one of them. And I think it's very much a system approach that needs to happen. It's not just maybe adult social care or SFT. There's a number of different things that need to take place. We're doing some collaborative work. So we're doing some focused work surrounding 7-day working and weekend discharges currently. And we're also working at the moment with NHS England and ADAS as well to really gain an understanding. Myself and the other deputy director from another local authority within the Southwest is part of that working group as well at the moment. So we're looking at some really focused events taking place within each of the acute hospitals to really understand that a bit more.
Okay, thank you. Thank you very much. Can I now go to, sorry, Councillor Watson.
Yeah, thanks, Chairman. Can I echo your remarks about the cancer side of this report? Because having been through it a couple of years ago, I have to say I was amazed by the treatment and the ongoing as well. I mean, every 3 months a nurse comes out to child now. I mean, it's absolutely amazing. So thank you for that personally, and I think for other people, everyone you speak to, the cancer care is fantastic. So thank you. The other thing, well, but going on from that is this only acute measures we're talking about today? Because there is other appointments, which the last one I heard about was a 9-month appointment for something to do with eyes. I don't know, quite some sort of eye appointment, and it was a 9-month wait. So I thought that's a bit excessive to say, really. But if we're only dealing with these matters on the agenda, well, yes. That just a point. And the other thing I am forced to say, I must say, is about the stroke unit. And has that been decided now? Have we dealt with that already?
Yes,
in this?
I think, Councillor, that's another agenda, another time.
Right.
In life. But thank you for your comments. Thank you very much.
Okay.
Thank you.
Thank you.
Can I go to Councillor Osborne online, please?
Thank you, Jill. Morning. Sorry I'm not there in person. I must be going senile. I got my meetings in a twist, but not to worry. What I was going to comment on was ambulance performance, and in particularly that it's still concerning that the category 2 call out is for the Somerset is 38.1 minutes against the 18-minute standard, and is probably slightly above the Southwest average. Martin raised it, but again, I really do hope that timing is factored into whatever decision is taken over the stroke unit, because I know that, and I've raised it before and others have, is a very, very major concern. And also as well, I know we had a presentation after a lot of, I think, persuading from the Ambulance Trust, and I would like to see that report or an update on all their statistics come back to us, because getting people to hospital quickly is an important part of the service. Thank you for the report. It's very clear. There's a hell of a lot of information in there, and it certainly gives you quite a view of the number of issues and the number of services that are now on offer. What I think I'd also be interested in, well, in terms of the cancer report, and yes, I think we all hear very good reports about that service in Somerset. I was still around when people had to go to Bristol for treatment, which happened to my mother-in-law in the 90s. So having a service in Somerset at Musgrove, you know, that has to be commended, and it certainly needs to, you know, be improved, and the diagnostic service should help. But I think what would be really useful is you've just opened up a self-referral opportunity to try and pick up on people who may have possible uterine gynecological cancers, that self-referral. I think it would be really useful once now that programme is opened to see how many referrals are being made by people. Are they taking you up on the offer of a self-referral? And of those referrals, how many come forward and how many of those lead to a positive diagnosis and hopefully early treatment for the people concerned?
Thank you very much, Councillor Osborne. We have already said that we will be calling the ambulance service. I think we've already put that on a forward plan. The ambulance service will come back with their findings within 6 months. I think we've made it might be a bit longer. So we've already categorised that because we know how important that is. Does anybody want to answer, Councillor? I mean, I think most of it was sort of done, but is there anything you'd like to comment, please?
I don't think so. And, you know, she, in terms of a category 2 performance, is down. I need to be taller, I think.
I have the same problem.
She, in terms of category 2 performance, and that's why we draw some of these things out. You know, try to get a balance in the report of the good and the things we still are challenged with. And I think, you know, it's fair to bring that out. With this significant investment gone into the South West Ambulance Service, which they've been able to do significant recruitment with, and also a number of extra vehicles on the road. So I think, you know, we're more than happy to bring that back. We've started pulling out some of the things. We aren't doing the justice in terms of that action plan that is being implemented in the short paragraphs we've done. So again, more than happy to link in with colleagues at the Ambulance Trust. There's probably a 2-part to this as well. So it's really important people get to hospital. It's also really important that people can then go into the hospital when they get there as well. So we are absolutely aware that those 2 parts need to work together to make sure people access those services when they need them.
Thank you very much. Going back to, that's really good. Thank you for that. I think Councillor Whale has said about the, I think there's one thing we don't want to do, that even though we're a scrutiny, what we don't want to do is not praise the good work that goes on. My husband has travelled the cancer route 12 years now, and excellent service, excellent, I mean, I have to say. So, but that's not to say that I want it to be even better for unfortunately new people. We want it to be better. The 13-day referral, and I gather that is still there. I think that we need that to be as quick as lightning for people, because I think that altogether contributes and helps their mental health when it's such a terrible time you're going through. And I think those 2 things are vitally important. But so what we'd actually said was, obviously we're calling the ambulance service are coming back with figures. So we talked to analyse the cancer figures, the skin cancer, the mental health. And I think what we could do is, I think what would be really good for us to do is to have a resource figures as well. Let us know what your resources are, you know, because I think that's vitally important to know, because, you know, without the good resource, I mean staff resource, you know, you can't complete anything without you've got the staff in place. And I think that's vitally important. So I think if that can be an update from yourself, I would really appreciate it, Alison, if that'd be okay. And thank you so much for coming today. Thank you very much. Really appreciate it. Thank you. Okay, now then, the members, I just wanted to let you know that the budget was just to see who was awake. It was entirely my fault, but Councillor Whale and Councillor Woods gets the prize, extra biscuit. So we will now go to the 6A, or the original 6, to talk about the budget report, please. Thank you so much. Thank you.
Thank you, Chair. Good morning, everybody. Chris Evans, Strategic Manager, Finance Business Partnering. There's a couple of slides to go along with this to make it a little bit easier to digest. So this is the month 5 budget monitoring report to the end of August. Scrutiny has been asked to consider if there are any comments or observations they wish to pass to the Executive Committee, and also if the actions set out in the report are appropriate and any other actions required. So from a corporate perspective, the projected outturn is £30.3 million adverse. So this represents a variance of about 6.1% on a budget of £493.4 million. So adults and children's are the majority of the variance, which I'm sure you'll be fully aware of. That totals £26.7 million at the overspend. Next slide, please. From an adult's perspective, the projected overspend is 14.9 million adverse against a budget of 185.5 million. So this represents an 8% overspend at this point. So this is a 2.8 million pounds increase overspend from month 4. So the increase from the previous month is due to additional delivery in home care and an increase in personal budgets via the direct payments. And finally, in commissioning the adults transformation, My Life, My Future will not be will not be achieved. The predicted saving in 23-24. It'll be in the future years. Happy to take any questions.
Thank you. I just, while I'm waiting for people to gather their thoughts, I just wanted to ask you on page 31 of your report, and it's obviously on the slides as well, the variance, the commissioning, sorry, on the commissioning, a vast amount there. I just wanted to, could you just elaborate a little bit more detail about that, please?
We did build in £5 million for the My Life, My Future savings into 23-24. The vast majority of that actually won't be made this year. It'll be made in future years, hence the size of the variance. But we are working on obviously that with New Europe.
Okay, thank you very much. Members, does anybody have any questions? I think the report is very well. I'm not great at budget, but I have to say, even I felt confident reading this, which is always a good one, because I think if I can understand it, then everyone else is going to be fine. So that's really good. I did have. I said, when do you feel we'll start the financial benefits from home care against the residential? Now I know we've asked that earlier, but I just wanted to know when you think the prediction will make a difference on our budget. Or do you have any idea, or is that, am I asking for something from the room?
That's a very good question. We are looking now at the medium-term financial plan going into 24, 25 and so on. So Penny has been tasked with rebasing the budget, looking at exactly what the demographics are, the costs coming through the market and so on and so forth. But obviously we are getting older generation, people are living longer. As you live longer, there are more complex cases to deal with. So the trajectories, as you will see nationally, you'll see through the press to various reports that it's only going one way, unfortunately, and that is up. So whichever way you look at numbers, you look at costs, it's all going in the wrong direction as far as budgets are concerned, and it's all going up. So to answer your question, it's unlikely to come down. It's just how we manage that budget with the income that we actually get in, which is extremely difficult for all authorities, and a lot of authorities, if you may, as in Birmingham and Woking, Croydon, they're issuing Section 114 notices, which means they're effectively run out of money. So we're trying to avoid that at the moment. Hence, there's a lot of challenge sessions around children and adults and all the other areas, to be honest. But I think, unfortunately, the figures are still looking extremely large.
I just personally wanted to be able to say to people, the reason we're doing this, the reason we are getting people being cared for at home is not only because it's better for them, not only because it's better for their mental health, their physical life, their whole well-being, it's also saving our country money. And I think we should somehow try to find that, to come into that. We should somehow be saying that. Maybe I'm wrong. We all want a better budget. Let's hope the government's listening. And, I think that, but I think we need to be saying as well that there is a cost implication, but to benefit people as well. I think the two things should be intrinsically linked. Do you think so, or am I wrong?
I agree.
I think we'd be unrealistic, and we want to keep people in their homes, obviously, we all want to be doing that, don't we? We, none of us want to go into a care home, I've experienced with my mum, we don't want to be doing it. But I think it'd be unrealistic for us to sit in this room today and say, we're not going to go, if we're living longer, we're not going to go in a home at some point. Well, the biggest problem we got is what I can see, we're doing a marvellous job of keeping people in their homes, but it's working really well, but we've got like an imbalance in them, because we've still got a lot of people in care homes. And what I think we've got to understand is we've had historically low care home fees. We're seeing those double now, and they're going to get more. You know, there's such a thing as inflation, and they say inflation's down. Yeah, I've seen fuel prices, they're not coming down very much. So to be honest, and we've got more people getting older. So I don't see, even with using we're doing, which is going to save us money, there's no question about it. I honestly think we'd be unrealistic to sit in this room thinking we're going to see budgets cut. They're not going to come down. They're going to keep increasing, as we've just heard. But it's how we manage that. And that's what we're working on, trying to do that. We're working hard, like little beavers trying to do that. But I'll assure you that we are going to see increased budgets for adults.
I don't think, I'm sorry, I may not have explained. What I'm trying to say is, with the eventuality of people not being in nursing homes and the very high cost, my mother was in there for 8 years, absolutely extraordinary price. What I'm saying is, I would like to think, in the end, that not only people being at home, living at home, being cared for at home, being where they want to be, would also eventually be a better saving cost. That's what I'm saying. Surely, in a way, that's got to be. We're not here just to make sure people's health. We're also here to save a bit of money. We've got to be, but that's the realistic, you know. Oh, thanks,
I think you're right to a certain extent. So I think there will be some individuals, and with the work that we've done with Newton Europe as part of My Life, My Future, has looked at exactly that. So it's looked at what the outcomes surrounding decision making, and did we get the right outcome for people, and therefore then the right cost for people as well. So there are some people that I think by supporting individuals at home, may cost initially a little bit more, but actually then that funding will dwindle down a little bit. I think that's the right thing to do. However, we also know that we're taken on from Dean's point, we can't support everybody to live at home, because there are some people that will need a significant amount of care at home, and that may include living care, so waking nights, one-to-one support. We're not able to sustain that sort of level of care within somebody's own home. So there will inevitably be times and that people will need to go into some sort of bedded facility. But what we need to make sure of is that when people are in also either a care home or in their own homes, is that having the right level of care at the right time. And that's where we're really looking in terms of the decision making for our workforce, and that's in collaboration with our health colleagues as well, that we're getting the right decision making for individuals.
Okay, thank you. I mean, absolutely right. We'll always be a nursing home needed, always be a nursing home. But let's hope that we can make sure that everyone eventually goes home. Councillor Well.
Thank you. As we look at the budget, and we were talking about Birmingham, places like that, we got to remember this is a statutory duty of the council. So other things may go, this won't. Let's be frank about it. Get down to the bones. So what we're trying to do, I suspect, is a Rolls-Royce service and not the three-wheel Del Boy thing. And that is the real balance that you guys have got to do, and it must be extremely difficult. And as I say, you're not going to be able to cut within your department the budget by that much. You're not going to be able to get down the gap figure. It's got to come from somewhere, and it isn't going to come from your department. It's going to have to go either from the council making cuts elsewhere, or from the government, who hopefully, whoever they may be, will give a grant, as they have in the past, I believe. Am I right in the fact that, was it last year they gave a lump sum to, and that's what we're looking for. But I don't think that we can pare down your budget, Dean, internally by very much. You can always do bits and pieces with this Newton and things like that. but it's help has got to come from elsewhere, and that really we can look at it as long as you like, but that's the reality of it, I believe. Thank you.
Thank you very much, councillor. Absolutely, absolutely, councillor.
Something that came up earlier, I'd call them hidden carers. They're not receiving any sort of allowances for caring for people. And given that we are aiming to try and keep more people at home for longer because it is better for them, the cost of hidden carers burnout. You're in there. So
Sorry, I've just got over hidden burnout. It took me 2 weeks on a cruise, but I'm back.
Councillor Woods, carry on, councillor, please. Councillor Woods, behave. Thank you.
So I am concerned that, or not concerned, but it would be good to know how many hidden carers there are that are not on in any demographic or any data set, and how we can try and find that out, because they are saving us a huge amount of money. Huge amounts of money, they must be. And the downsides to that later on in their lives, actually, it's hard work for their mental health, it's hard work for their pockets personally, and it's possibly even hard work for their physical health as well. So we're actually possibly even creating another problem with those hidden carers. Now, carers that we know about, that are within data sets, they do get alternative support, they do get available support, and quite often those hidden carers get a lot less. So I think that if there's any way we can look at hidden carers and notice that they're there and make sure they're okay somehow, that may actually help keep people at home longer, because you don't get that burnout, you don't get those people struggling that you don't really know about.
Thank you very much. Alison, perhaps you could add that to your list. I think that's probably coming more to you in some respects, hidden carers. It'll be you, would it? Okay, sorry, Alison, I'm just trying to, I could see the look on your face. Okay. Just, I mean, we're all working in the same pot here, do you know what I mean?
On that point, please.
Okay, I've just got to go to, well, I'll be very, could you
Very
done
quick.
very, very quick, please?
Certainly in my area, I know of 2 or 3 others, there are voluntary carers groups set up in lots of locations, and they are very effective. There's certainly one in Chard, and maybe one in Ilminster, I'm not sure. But they are self-funding. They're quite happy being self-funding, oddly enough. And they are they do a tremendous amount of work. So it is there is a voluntary sector out there. Thank you, Chair.
Thank you very much. I have to say, I'm looking after my parents. I think we all do. As you get older, you look after your parents and look after other people. I've looked after neighbours, and I think it's what we all do. I think it's a good thing. Thank goodness we're in this. But can I go to who's waited patiently? Councillor Osborne, please.
Thank you, Chairman. A couple of points on this report. When we did all the Newton costings and the savings based on Newton, what sort of a factor did we build in for an increase in demand? Because all the figures and infographics point that the demand for the statutory service, adult social care, is going to increase. And in turn, how much of the savings that we make we're actually going to need to hang on to ourselves to be able to meet that increase in statutory demand. My second point is that I think last month I asked if we could have a breakdown of, although this is a statutory service, not all parts of it are statutory, some bits of it are discretionary. And I suspect the bits that are discretionary are the bits that cover looking after the carers, caring for the carers, and possibly supporting or trying to identify those hidden carers, and also ensure that they are aware of what support is available. That would be really helpful to know what we have to provide and what's discretionary. And also within that, what element of the discretionary service underpin the statutory, and if you remove that discretionary, the impact it would have on your statutory as well. because as you say, we've got very little wriggle room in Somerset, because as Dean observed earlier in his report, Somerset is one of the lowest payers for care home fees. So there's no fat to cut there, because we're already at the bottom of the market, and we do suffer from other authorities coming in and buying beds here. It can be quite a problem at times. So it's not going to be an easy portfolio, and has been pointed out, it's going to be challenging. It's going to be challenging, but I'm just concerned how much of those Newton savings are actually going to wind up, going in as a general saving, and how much of those savings are we going to have to retain ourselves in order to keep the service going.
Thank you very much, Councillor Osborne. Councillor Reddle, would you like to come in first, please?
I think that obviously we're going to get you to the savings, but I think the pressure on our services, you basically are just going to make it slightly easier than our budget, but it's not going to it's going to have an impact, obviously, for the amount of money we're going to save, but overall the impact's not going to be as much as we would, over the service, how much we're spending, we're intending to spend next year is not going to make that much of an impact on the pressures we're having on our services. As for the non-statutory services, that's the first thing I looked at, of course, when you're looking to try to save, when you try to make savings, okay? And we haven't got, our non-statutory services employing, they're very small. I think the last one I saw about £1.2 million, roughly. And that's village agents, silks, all stuff that we can't cut, because if we cut, it's going to come back and bite us. We can do it. If that's what the council wants to do, we can do that. But I know, my commercial knowledge tells me, my mind tells me that in 2 years' time, we're going to pay. And that's some of the cuts we've made in the past. That is why we're now paying now. And that is the problem we got. Basically, we have not got enough money coming into the system. We're 14% below the national average spend in Somerset on spend. Okay, we got the increase now, so which brings us up to 8, still 6% below. 6% on the budget we're talking about is a massive amount of money. We have historically been a low spender on adults, and we no longer can be. Pressure's on us, we just cannot do it. I'm being totally honest with you. And as Martin said, he's right, it's the statutory service, and we're going to have to make savings elsewhere if we want to survive.
I think what we're all trying to say, though, I think if I can just say, I think we all are aware. I think once we, you talk about trimming the fat, don't we? Just to make sure that we're absolutely certain we're not wasting anything anywhere. I think that would be wrong of the scrutiny committee not to be trying to say, are we looking at every possible 14 million, is a massive. What we're saying is we need to ensure, all the committee needs to be confident that we're not wasting any money anywhere. And that would be wrong of us not to be looking in that way.
I'm not arguing that. I'm just trying to tell you the truth of the situation we sit. And in all organisations, there will be a small amount of waste because it's a massive organisation. But we are pretty much firefighting in adult social care. I'll be honest with you.
Well,
and I feel so sorry for our officers who are every day are trying to make savings for it, and they're just not there. I've looked at it pretty much. I'm pretty well into this. Penny knows that. Mel knows that, and we're pretty much the borough to be on the borough to be up to empty. Sorry.
It's always a difficult one because it's a very emotive subject. We all want the best health, we want the best service, we want everything the best, but we're obviously a massive overspend, and that's a big worry. But absolutely, but at least I think we need to say these things. I think this committee needs to say it out there on the table, how we're feeling, and then we know then we're working in transparency. Okay, so anyone else on the committee would like to say anything?
Sorry, can I just come back on that? I mean, that has been my concern. I'm very glad to hear that Dean will do whatever he can to ensure that that discretionary element, as you say, the village agents, the other things we fund, that we will try and continue to fund those for as long as we can, because you are right. You pay later on down the line. It's like saving sixpence now, only to find it costs you a shilling a few months later, and that's not good for anybody. I think we all know how tight the budget is. It is statutory. There's very little room for manoeuvre here, and yes, savings are going to have to be made elsewhere because this is a statutory service. It's a critically important statutory service, and demand is going to increase. And also I suspect that demand for some of the more discretionary element of it will also increase as more people come into the system. As you say, none of us are getting any younger. And there's also a lot of people of working age that come under adult social care as well, the moment you hit 18. So if there is a knock-on from children's, because the children's casework increases, it will feed into us the moment those children turn 18, and will still need looking after, will still need care. So, you know, we all tend to focus on the older age, but this is a service that covers you from 18 plus, which is huge. And some of the demands at all levels can be very complex. So there is a challenge there. Someone at some point, whoever is in government, whatever colour, and let's stop pointing fingers of blame at who did what to whom and when. Someone is going to have to grip this problem eventually, because it can't just keep being funded by ad hoc bungs of money. And when those bits of money come to prop you up, they come for very specific purposes. The money we had last year was actually, the theme was actually to reduce the length of time as discharge. It was basically to solve what was known as the bed blocking problem. So you were getting people out of hospital and into other facilities, other solutions quicker. And I know Mel and the team had to do an awful lot of paperwork to justify that funding. There was certainly quite a lot of officer input in providing those returns, because without the returns, you won't get that grant funding. So there's no easy solution. Someone's going to have to grip it at some point. And I think when Theresa May tried to grip it, unfortunately, as part of an election campaign, the baby got thrown out with the bathwater, and it seemed as though that conversation seemed to stop, which was in a way a shame, because, you know, we are where we are with this. And I am pleased to hear that it's a very small amount that goes on the discretionary element, and that will do what you can to retain that.
Thank you very much, Councillor Osborne. Thank you. I don't think the baby's had a bath for a long time, but I think you're absolutely right. Councillor Woods.
You've got it right there. What we're talking about here is family values. We are picking up now the family values we lost within the last 20 years, at least. So if we can get back to families understanding the person that looks after the elderly, the person that looks after the children is themselves. I'm sorry about that.
Okay,
That's
thank you, Councillor Woods. Thank you. Chris, you would like to say something?
Yeah, just to pick it up on a couple of points generally. So as far as not just adults, but all of the services, so we're currently going through a really big exercise at the moment with challenge sessions for all the directorates. So Penny has spent a lot of time pretty much going through all of the budgets. Bear in mind it's 185 million, going through all of the budgets pretty much line by line with Mel and Emily and Paul and so on, looking for any savings that can be trimmed off. That's been replicated across children's, across climate place, communities, central services. So that's going on at the moment. Obviously, bearing in mind the financial position we're in. So that's the level we're going down to with directors, looking at every single line of the budget pretty much. And the second point to make is nationally, obviously there have been a lot of councils in the press that have got themselves into trouble. In Woking, Birmingham recently. But what we're seeing now nationally is a lot of authorities are about to run out of money through no fault of their own. So some of the decisions have been really poor in the past, and that's well documented. But now we are in Somerset, we're having massive pressures within adults and children, and the costs and the numbers are going through the roof, and we're just not getting the funding. So it's not anyone's fault. And there's a whole pack of councils that are now going into that territory of issuing 114s. It'd be interesting to see in February when they set their budgets for 24, 25, how many all of a sudden will be issuing their section 114 notices, because they've literally run out of money. They can't afford the services, certainly children and adults, and they've run out of reserves. So that's the difference now. It's gone from councils getting themselves in trouble through bad decisions to actually this isn't anybody's fault.
And to be fair, I think that's the transparency that we need. As a good scrutiny committee, we need to know that we've scrutinised every area, every corner, every bit, to know that we're not wasting any money. There's nothing going awry. This is circumstantial. This is how it is. And I think that's what we need to be able to identify. And I think as long as we can feel confident that we are scrutinising every element to make certain that our statutory and non-statutory is being cared for as well, then I think that's very, very important. So I'd like to thank you for today. You think you've done a great job. I'd also like to thank our finance officers, and I'm not an enviable position. I'm sorry, but well done. And thank you very much for the good, precise reports today, because it's really certainly helped. And thank you very much. Okay, so you don't have to, but if you want to.
No, it's fine. Sorry, I just want to note at the end of item 5, there was a winter planning update, but unfortunately my colleague Sheila Melgens had to leave, so we can bring that back. It was really probably linked in with a lot of the conversations we've been having about how we're preparing for the winter period, and Sheila's leading that with colleagues across the ICS, so we can bring that back.
Absolutely. Well, even a report coming in we can send out to members would be really, really good. Thank you so much. Thank you very much for today. Thank you. Sorry, Councillor.
Yeah, given that winter's not that far away now, are there any headlines that we could be given, things we could be thinking about? Thank you.
I think it's the themes we've been talking about all morning. I don't think there's anything different in terms of, we're expecting a busy winter. We hear that a lot, so the collective planning we're doing in order to respond to that is really important. We probably picked up most of the themes this morning, but I can ask Sheila with colleagues to bring them back if that'd be useful.
Thank you. I think the advertising of the flu jabs and the COVID and all the things accessible, so reminding people that protect yourself. Because I think some things we do forget is about self-help. It's about us preparing ourselves for the winter, not expecting the NHS to look after us. Actually, put your woolly socks on and don't take your vest off, as my mum would say, until spring. And I think that will definitely help. So thank you very much. Thank you so much for today. Thank you. I really appreciate everything. Okay, this is item 7 now, just to make sure we've got this right. And this is the dentistry. This needs to finish by 12 o'clock, just to give you, I'm sure it will, because but you've got plenty of time. So over to, sorry.
I take the public question.
Oh, I haven't done it yet. Wait a minute. He's just going to do it. And we have a public letter from a lady that's often a subscriber to our committee. So Jamie is going to read the letter out and then we'll go over to you. Thank you.
Thank you, Chair. The public speaker had been online several times this morning, but isn't currently present at the moment. So I will read out the statement that was submitted. So many people are not registered as NHS patients. Approximately 50% are unfunded. With the cost of living crisis, many people up and down the country with severe dental problems are pulling their own teeth out because they can't afford to visit a private dentist. Dental examinations can reveal serious health conditions such as oral cancer, heart disease, and are necessary for women who are pregnant. Serious health problems are not being spotted early enough. Children are being admitted as emergency patients. Their teeth are so bad due to caregivers being unable to afford private dentistry. This has led to even more strain on an already overloaded health system. Question 1, for people who are not registered as an NHS patient, how long will it be before they can register as a new NHS patient in Somerset? Question 2, what happened at the national consultation and what was the result?
I'd like to thank Eva for that letter, and we will ensure that we get that answered. So I'd like to pass over to Sakina Kassam, beautiful name, and I'm sorry, and your colleague is Matthew. Is it Matthew? Matthew at Mill. So over to you. Thank you very much. Sorry. No, it's not. That was an old battery in that one. I'm so sorry I didn't move it. My apologies.
I've also got Tessa Fielding, who's our dental programme lead across the South West region and supports Somerset as well. And Matthew Gerrard, who's a consultant in restorative dentistry, that's also the chair of the dental network and has other national roles as well, and is actually a local consultant at one of our local hospitals here as well. who's on, and they are online to answer any questions from.
Thank you.
So in response to the question that we received from the public, for people who are not registered as NHS patients, how long will it be before they can register? I have provided a written response. However, I just wanted to sort of expand that the way patients engage with dentistry has evolved. So the traditional registration at a dental practice no longer exists. A patient is at a dentist during the course of their treatment. So it's not similar to how you're registered with the general medical services, the GPs. And we've sort of provided in the written response how patients can look for a dental surgery online or by making contact via telephone. And it's just to let you know that we have recently had a written notification from the Minister of Health. It literally came through yesterday in terms of some next steps that we're going to be taking to check on contractual compliance around advertising acceptance of NHS patients as well. So that's something we'll be looking into as a team. Additionally, I just wanted to sort of mention that there are some local initiatives we've been looking at, and I don't know those of you that are here, we've recently taken on delegated responsibility as NHS Somerset ICB from the 1st of April 2023 of dental commissioning along with pharmacy and optometry. So Tessa and colleagues across the South West region are now supporting the local NHS Somerset teams and myself and Matt. We've just recently appointed Matt, who's sitting up on my right, as our head of pharmacy, optometry and dental services. So some of the work that we've been doing locally to address some of these access issues are we've started looking at a stabilisation project locally, and we're doing some reviews of that stabilisation project. And we'll be looking at other initiatives through a dental network, which we've already convened, and we're working quite closely with the local dental committee, including dental practices, local public health experts, and obviously Matthew Jarrett and his sort of dental network team as well. So we're looking at developing new care pathways and identifying other opportunities to expand dental capacity. We know that there is actually a national problem with dental access. The contributions of that are that the National Dental Contract and the way the UDA activity is being commissioned isn't something that dentists are finding financially viable. And there are some imminent contract changes that we've been informed are also due to follow. I'm going to bring in Tess or Matt if I've missed anything online, but have I answered that question correctly? Have I missed anything?
No, not at all. No.
Brilliant, thank you. And then the second question was what has happened at a national consultation and what was the result? So we were a little bit, so I have asked a question back saying regarding the inquiry about the national consultation, it's important to clarify which quite a lot of work going on nationally with dental developments. What we are aware of are the ongoing national changes, which I've sort of just mentioned, including the revisions to the units of dental activity, which is referred to as, which is the contractual UDA form. So there is an imminent release of the dentistry recovery plan that we're waiting for, which is something that we've been written to about, but we're just waiting for the detail. These changes, coupled with further adjustments to the National Dental Contract, are aimed at enhancing patient access to dental care, and obviously hoping that those changes and reforms will enable NHS dentistry to be a bit more attractive, because at the moment, the way the current state of the dental contract is not attracting NHS dentists to continue with the NHS activity, because it's just not financially viable. And I think it's also quite important to note that the national economic impact around rising costs for inflation, rental, workforce, is having an impact on not just dentistry, but also pharmacy as well. So there is a national economic impact that we are seeing on dental contracts and pharmacy contracts across the board.
Can I come in on just add another thing as well? I think the flexible commissioning and populational health document that will come from the national team will actually help support NHS dentists, providing you mentioned stabilisation services. There are other incentives for dentists to work on sessional rates to support the inequality patient groups, and that flexible commissioning document will give you, as well as the NHS commissioning team, the opportunity to flexibly commission NHS dentists working in primary care to deliver those health inequality areas, which will increase access. But again, we're just waiting for the final document to help. Although we've already got a spectrum of services that we would then be able to use based on the different areas in Somerset and what is needed in different parts.
Can I ask when do you think that the document will be available? Because as you know, we've been waiting and waiting. Dentistry is very, very high on our agenda as well as everything else. But it is a major thing that keeps coming back and coming back. And we always seem to be waiting for something. I'm sorry, but it just feels a little bit frustrating from our point of view as well. So
yeah,
we don't want...
sorry. So so frustrating for you, but also frustrating for us because it's a national team that are producing the document. We are actually already carrying out the flexible commissioning, and as Scrutiny said, we're looking at we've actually got stabilisation services across the region. I think the document that is imminent, and Tess has put her hand up. When I'm hoping, in the next couple of weeks, it will give us a bit more guidance on the other options that are available as well. But I'll let Tess come in.
Yeah, I think the document that Matt's referring to with reference to flexible commissioning or alternative commissioning methods is another way forward. But needless to say, the actual overall national contract reform still is ongoing. So the step changes. So there was the first step change, which was last year, October. Flexible commissioning will be another step change. There will be another step change that's due. So essentially, they're working their way through those changes. So it's not going to ever be a short process, but they are a dedicated team looking at options and how they can progress national contract reform.
The letter that we've had from Minister Neil O'Brien has just come through on the 29th of September, and it was written on the 29th, but we've just received it yesterday. So our chief exec, and that's sort of just saying that we'll be aware that soon a dentistry recovery plan is going to be published, combined with further changes to the dental contract. So we've been written to, but there's no detail yet. So we haven't seen the detail, and without that we can't sort of move forward. But what we have done is we did provide, so we have collated a PowerPoint, which has got some schemes that we're already starting to work on. I apologise that it's not been sent out in advance of this meeting, but on the last two slides, there are all the schemes that we're actually working on or considering at the moment as a dental operational working group across Somerset, and some of those schemes are also being worked across the South West region as well. And Matthew and the Dental Network are supporting us with that.
Well, now we've got you sat in the room, I actually think we probably won't let you go, because it's taken a while for us to get you. I believe this subject is really, really a serious subject. We don't want to go back to the string on the door handle and pulling our own teeth out. Has been mentioned. That's something it's not going to happen. I wouldn't do that. But I think on a serious note, there are so many implications with dentistry. The fact that people are having so difficult getting to an NHS dentist who cannot afford. We know there's a private scheme out there, but you know, it shouldn't be that way, and I think we've got to, so would it be okay, you need to come back, obviously, with your report, obviously, I think everyone will agree, so we need to get you back, within the level of time, 2 months, or put you down for the 3 months or something, do you think you'd have, you know, we just don't want to lose sight of you, Seema, I need to keep you here.
Yeah, so
I may take you home with me, in fact, you know.
it's probably worth noting that the Somerset ICB, we've only just taken on dental commissioning. So this did sit with NHS England, and through the new delegated responsibilities, we've taken this on. And that's where we've got opportunities to work locally as an integrated system. We've probably not got time to run through the slides, but I'm happy for us to share the slides with the committee. I've been asked to come back to the children's review and scrutiny committee on the 25th of October, but actually our work streams work across both. So we are working on child oral health initiatives as part of the adult oral health initiatives. I know Matthew's got his hand up, so I'm going to let him come in.
Sorry, Sakina, can I just, the 25th of October meeting is actually a joint committee meeting with this committee and Children and Families, so everyone here present.
Where sort of us sharing these slides, and then we have a little bit more time, concentrated approach. Okay, but I'll let Matt and Tess come in as well, because we've got them at the moment and they're the specialists.
Thank you very much. Can we, Matthew, is it Matt?
Yeah, Matt is fine. Sorry, I don't know your name, apologies. But you just said something. You said, it just picked up a point. And I think there's a little bit of a lack of understanding, and I think it would be really great for us to support Sakini and the ICBs and having a proper quality time with you to go through the work that we're doing and some of the understanding of dentistry, because actually NHS patients there's only a 50% funding for the population. So even if you were aiming to try and fund 100% of Somerset, which we know a percentage will go for private treatment, a percentage don't like seeing a dentist, we're not going to deliver all patients. And so actually one of the things that we can do, and we are working with Somerset ICB, is actually have a charter. So actually there's an expectation for patients, an expectation for the dentist on the other side treating those patients. And I think that's something that we really need, that message, that communication out is really helpful. And actually this is where yourselves as councillors and MPs can then go back up the food chain to government and actually try and get more funding for NHS so that we can actually increase that perceived 50% population and increase it further. And that will then go across primary care, secondary care and community. But again, I'd probably ask by saying that I've given you another 20 questions you want to ask. So apologies, but I think that's an important point to raise at this point.
Actually, the slide deck that we prepared has got a little bit of context and information. So, I've got something around what the current service contracts are, how much sort of units, the UVAs that we contract, how many we're contracting, how many contracts we've got. So we've got 67 contracts across Somerset, what our actual financial envelope is. But like Matt said, it's sort of worth noting that the funding that we've got is just for 50% of what's required. So we've got limitations, but worth also noting that we're not currently spending all of that because dentists are not providing their current full contract values as well. There are some in some of the areas that are and some that aren't.
Thank you very much for that. Thank you. Can I go to Tessa Fielding, please?
Thank you. So I was just going to follow up on what Matt was saying. So what we've done for other areas, because I cover 4 ICB areas, so what we've done for other areas is done what we call as a masterclass, a dental masterclass, and that's kind of a positive offer back actually, if any of the members would like to attend a dental masterclass, because dental contracting is like no other. It's very complex. We talk a very strange language when we're talking about dental contracting and how we measure, how we monitor the contracts, and how we can look at opportunities of spending money on underspend, etc. So it's quite complex. So that's just an offer that I'd just like to put out there. If that's something that everybody would like to pick up on, we could do a Somerset Dental Masterclass where we would go into a a lot more detail really about the contracting method and some of the real risks and challenges that we've got, because we can say it's down to the lack of dentists, but it's actually a lot more deeper in terms of the contracting model as well. So yeah, just as a positive offer really.
Thank you very much. That's something we can get our teeth into, isn't it? I think we definitely need that. So thank you very much. Can I go to Councillor Osborne, please?
Thank you, Jill. A couple of points raised. I think on dentistry, I think the sort of shortage of dentists, particularly in Somerset, has been going on for some time. When we first moved down here in the 90s, although I lived in Ilminster, we actually there was no one in Ilminster prepared to take us on. At that point, we'd hit the point we didn't need to see a dentist. And we wound up with a dentist in Martock who took the view that actually it's quite nice to have a bit of new blood on the client book. Otherwise, we were struggling. So we're quite fortunate, but we have remained as private patients. And I can tell you that it is quite a stretch because you have to pay instantly. This is another factor. You have to pay by card and it's instant. So the model a lot of practices now have is they get the money instantly from the card. Anecdotally, I have heard comments that if you do NHS work, you then might find yourself having to wait 4 months before the invoice is paid, and their businesses are not configured to carry outstanding invoices for that length of time.
Could you give us the question, Sue? I'm sorry to interrupt you, but could you?
The question is basically how much, in terms of that, how much of a factor is the quickness, the rapidity that a dentist gets paid for the work they do? Also, a barrier to entry, how do we overcome this, is that some people may find they haven't got access to limitless credit. So if the dentists are insisting that new patients pay up front or you pay on the nail, so to speak, that makes it very hard. So how can that be overcome? As that is some of the problem. And you've now taken on this work. So when do you anticipate that we will start to see a fundamental increase in NHS dentists? Because there are some parts of the world where it is an NHS dentist desert and people are having to travel miles out of Somerset for treatment. So I think we need to see a bit of a timeline on that. Yes, please, a masterclass would be handy. But you mentioned the fact that the contracts are complex. Is that possibly some of the problem, that maybe you've made it so complicated that in itself is a barrier to entry? Yes, please. I know you've got pharmacy on there. We're starting to see concerns flagged up about pharmacy, which is worrying, as that is a major plank of the how to take the pressure off the GP and the
Sue, can I just get the officer to answer, please? Because we are running out of time. So can I just get them to answer? Is that okay?
I'm gonna bring in Tess about the invoicing element. We can't actually comment on private dentistry and their operational processes because they're all different entities. So I'll bring Tess in just to answer the NHS element of this.
Thank you.
Thanks, Akina. So the contract is a national contract. It's not a contract that we set locally. It's a national contract that we work to across all of England. The way that dentists are paid is they are paid in what we call units of dental activity. So you'll hear us talking about UDAs, for example. They make up, so a UDA is how we would measure what patient's treatment they've had, for example. Now, a dentist would start the beginning of the year on the 1st of April with a contract. They have, that contract is there. Their contract's in perpetuity in some cases. They receive the money on 12 equal monthly instalments. There's no wait, there's no delay for payment. Dentists receive 12 equal monthly instalments of that contract from day one, 1st of April. What we then do is adjust the payments that dentist would receive in year and sometimes at the end of the year if they have underperformed on their contract. So there is no wait and there is no delay whatsoever in a dentist receiving money. They actually get paid on a monthly basis, 1/12 of their total contract sum. What comes off the bottom line of that then is what the patients pay across the counter. So the patients will pay their patient charge revenue that comes off of the bottom. And just to talk about in payment terms, the contract mechanism is such that they can ask for money up front. The payments are banded according to how much work you're having done in a dental practice. So if you went for an examination, you're in the measure of £26, for example. If you're having a filling, you're around £60. A lot of practices will ask for money up front, and there's a mechanism and a reason for that, because historically, if patients didn't turn up, it's an incentive to get patients to come back to have that treatment done. You don't necessarily have to pay until the end of the course of treatment, but other dentists will use that as an opportunity to space out the costs. So perhaps you might pay the £26 at the first visit, and at the second visit you'll pay the balance up to the £60 because that's what your treatment costed. So so I'm not, like Sakina says, we're not here to comment on private practices and how they operate in terms of getting money up front, but there is a mechanism there to secure, and it's typically used in practices to ensure that the patient comes for the next appointment. As you can imagine, there's a very high DNA rate in NHS dentistry. A lot of patients, believe it or not, even though they have an appointment, still don't attend the practice.
Okay, thank you very much. Can I go to Councillor Sully, please?
Thank you, Chair. Is there a safety net? I need to understand that. I'm sitting here on behalf of a young family based in Evercreech. The mum has end-stage kidney failure, and she has just got settled status from the Home Office. She's American born, and she's been battling these unfair rules for 2 years, and it seems it was a mistake with the Home Office. But they've just had their dentist, NHS dentist, kick them off and kick them out. And because that NHS dentist is now taking private patients. And my question is, what is the safety net for families like that? I mean, they are crushed by the cost of living, and this is the final, sorry for the pun, final kick in the teeth for them after all they've been through the last couple of years and her ill health. But what is the safety net for families with dentistry in Somerset, in Mendip South, in Evercreech?
Anyway.
Or anywhere, my colleague just said, but anywhere, and hear for them this specific question.
Do you want to answer?
Matt's got his hand up, and I'm going to bring Tess back.
Sorry,
in.
Matt, it's very difficult. I can't quite see in the light, so apologies.
No, it's fine. Don't worry. Well, I mean, that isn't one story or one real life patient. That's multiply that by a number. What we can't do is force dentists to take on patients when they give up their NHS contracts. And as I say, I think it'd be really good to have that webinar and deep dive into dentistry for everyone, because, without going into more detail, there are reasons why that's happening. I think that the key message here is we notice those inequality patient groups, and some of the things that we're doing around, and Sakina, on the slides has demonstrated, is actually making sure that those inner patient groups that are going to struggle are managed. And that's then where the flexible commissioning of our current NHS contracts can be supported, to make sure that rather than seeing the healthy population that maybe have a checkup, they actually see the inequality groups that need access to dentistry and provide that kind of stabilisation service and support. And I think and that comes back to then the charter, making sure that patients know that actually they're not maybe needing to see a dentist every 6 months if they're healthy. They may actually only need to be seen every 2 years for a checkup. And I think those perceptions that we face have had an impact on dentistry. And so if we want to treat the patient that we've just heard about, we need to actually make sure those inequality groups are actually managed properly. And that's supporting the NHS dentists providing those NHS contracts.
Chair, is that okay to reply?
Councillor Sully just wishes to reply, Matt, if that's okay.
Yeah, no, I saw a hand, sorry. Thank you.
So my question was, is there a safety net? And it sounds like you're saying there isn't a safety net, but there may be a charter in the future.
No, so I think you're right. There isn't a safety net, because you can't force those patients to go into those practices. What we're trying to do is make sure that, say, for example, children, adults, that are in those groups that are struggling, that can access dentistry, that there are those in effect provisions to provide those patients through, most likely your patient you're talking about through 111 at the moment. But actually, if we had a network of practices, child-focused dental practices, stabilisation services, other pilot projects that we're working across region within Somerset going forward, then those patients would be then in effect protected. But again, at the same time, we cannot, and we're not in a position to force dentists to take on that patient. So, you know, the safety net aspect is not an option, but we can try and provide the resources to make sure those patients then find access when they need it. And that's the provision that we're trying to deliver.
And just to come in, so Matt and I are actually writing out to, so we're both fairly new in post, so I'm sort of 12 weeks in post and Matt 6 weeks in post. So we're literally just drafting an introduction letter to our dentists as well. And this is part of the work that we're doing around sort of local initiatives. But like Matt online is saying, is that we're looking at what initiatives as a dental operational group can we prioritise with the funding that we've got, because we have got funding that we can use because of the understand. But look at it with a population health and health inequalities eye rather than sort of so it's quite targeted. So that's the aspiration.
I did pick up on the point you said earlier about it's not attractive. We need to make it more attractive to have dentists. I mean, thank goodness our doctors don't need it to be too attractive, because it just feels wrong. Why aren't we getting the dentists? I mean, and we need more, just the inequalities of for people, families not being able to get a dentist. That's all there is. Councillor Osborne said it's a bit complicated. It does appear to be a little bit complicated, in fairness, you know. So
I'm going to bring Matt in because actually we've recently just had a meeting with the Chief Dental Officer as well here, because we hosted it, Matt, at the hospital here. So I'm going to bring him in because there is work underway at the moment where we're looking at different attractive workforce initiatives so that we can start thinking out of the box.
So yeah, thanks. So I think workforce is the big issue, and obviously to try and make it attractive, there are some models that we're exploring, and other ICBs are as well. One of those could be actually supporting training needs for the younger dentists that have just qualified. They come out with dental school with up to maybe 40, 50, even maybe more £1,000 worth of debt. And you can imagine now going into a place where maybe accommodation costs and costs of living are high. Appreciate that dentists may earn a stable salary. Actually, how do we support those those dentists in that environment? So actually, as counsellors, is there an opportunity to reduce housing costs for new dentists coming in? That would be an incentive that would provide, looking at business rates for those dentists that maybe want to set up a service. That could be something that as a counsellors you could actually be productive in doing. But from the ICB perspective, is there a way of supporting that early stage debt by helping them train, improve their skills? There may be that incentive then therefore to stay within the NHS, looking at different aspects of dentistry, not just specialist level like something I do, but maybe it's something in between. And I think those things are attractive. And it's not just in a golden handshake to come into region, it's supporting them staying in region. And there's some definite evidence that if we can encourage a younger dentist to stay in region, support their training needs, they're most likely to stay within that footprint rather than move away, because obviously as families, etc. So I think those things are being worked on, and we have a workforce arm to our reform programme regionally, and obviously we support each of the ICBs with that. So again, that's another aspect that we could bring into our webinar and give you more info, as it were.
thank you. Okay, I've got a councillor here, and I've got two online, and then that's it. Okay, I think we've really given this a good thrashing. So, councillor first, please.
Thank you for being here, and I appreciate that everything's very, very new, and brainstorming everything to try and get it right is an incredible feat. First of all, can I ask, is there any consideration being given to the use of the Chard ADP practice that's now shut, it being a purpose-built dental practice, which isn't very old at all? I'd like to know where the records have gone, and whether that can be utilised for up-and-coming dentists as a training centre, something. So losing that in Chard has been quite a dramatic thing for not just Chard, but probably somewhere in the region of a good 25 to 40,000 people, potential patients. And the other thing is there any funding considerations towards public health and education of good dental practice? You know, sort of schemes within schools or, you know, groups, I don't know, to increase dental care. Thank you.
Tess has got a hand up because child is our regular topic, isn't it?
It is. Yeah, Chad's Chad is a hot topic for us, absolutely, and understanding that loss provision. So we are looking at ways we can utilise that building because that's an NHSBS property that had a dental practice in there. So there are various plans afoot, if you like, to just to try and utilise that building. So absolutely on the radar. So the other thing about, you just mentioned briefly about the records. So the previous provider that was in there was a corporate provider. So dental records that were in there would have been taken away and securely located in a further practice or into a secure setting. So they're not in the practice anymore, the dental records. So so yes, it's very much on the radar. And I can't remember what the second part of the question was now.
Well, it'd be interesting for patients to know where those records are. And the second question was public health funding. Or money going from the ICB dentistry pot towards public health.
Ah, right, okay, yeah. So
better education for dental care.
Yeah, so the dental records, just to tidy up on that one, the dental records don't get transferred like medical records. If a patient was to move around and go from practice to practice to practice, they would create new records. The records actually remain the responsibility of the dentist, so they actually own those clinical records, if you like. A person's perfectly able to ask requests for access to their historic records, and you know that we can sort of obviously facilitate that even when a practice closes down to have that onward access to records. In terms of public health and supporting initiatives, we have a really good team in Somerset, the local authority team, or led by the local authority team, that deliver really good oral health initiatives across Somerset. One of the most proactive ICBs, I would suggest, in terms of that sort of support from public health. We also have a new initiative that is due to start that we've recently commissioned, which is supervised toothbrushing. Supervised toothbrushing specifically targets children in the most deprived school areas. So this is in year one of schools and sometimes nurseries as well, where the children are in the most deprived areas, where we actually have a provider that goes into schools, trains the staff and in the schools to be actually supervise children to brush their teeth once a day, every day, supply home packs to take home so that they give them packs to take home over the Christmas holidays, the Easter holidays, because we find that in some of the most deprived areas, actually even owning a toothbrush or buying toothpaste is sometimes quite challenging. So that's a really good initiative that's due to start quite soon. So we're really pleased with that initiative. And there's another further initiative for young children, which is called First Dental Steps. And again, that's where a provider trains health visitors in the key oral health messages and provides toothbrushes, the right type of drinking cup for a child as they're going away from the bottle or breast into drinking, to help make sure that they are actually getting some key oral health messages across. So there's quite a lot of initiatives that are happening for our younger community across Somerset to try and get in early doors.
Thank you very much.
Thank you. It's good to hear about those initiatives. That's really, really good. Okay, our last two speakers now, please. Can we have Councillor Andrew Govier, please?
Yes, thank you, Chair. So apologies that I haven't been able to join you in person today, transport difficulties, but thank the speakers. I'd be very interested in having a more in-depth discussion on this, because I think it would really benefit. It is one of the major issues I think we face at the moment, NHS dentistry. I am frustrated that the last time we had dentistry, I believe it was the beginning of 2022, came to the committee, and at that time a Tess was telling us that there was about to be some new contracts let to, you know, that they were looking at areas which were unmet need across the county, but I've not been made aware that, and I don't know whether the upheaval and the change in structure has happened, but certainly in my own area that the situation as far as NHS dentistry hasn't improved, and I'm pleased to hear there might be something coming down the chain about the national contract, because I believe that's probably one of the root causes of the problem. But you know, I'd just like some reassurance that there is something going to happen, because we've sort of more or less told this over a year and a half ago, and really it's taken a long time to get people back here. And I understand, you know, the two members of staff are relatively new but you know, the situation is bad, and people are still suffering out there, and people on a day-to-day basis are in pain and can't afford to get treatment. So you know, I agree. I understand the reasons for a delay, but you know, I think we need to treat this as a matter of urgency, and I'd certainly welcome on that a get together and talk about this in depth. But thank you.
We're happy to work with yourselves and organise a detailed webinar and you know, and do a little bit of sort of information loading.
That would be really, really good. Can we now go to, and thank you very much, Councillor Govia. I'm sorry you couldn't get here today, because I know you always try to get here, always, wherever we are. So good to see you online.
Can I just bring Tess back in, because she wanted to respond to Councillor.
Okay, we've got one more speaker after, okay.
Very, very briefly, just in response to the previous councillor around the what we called phase 1 reprocurement of activity. So this was replacing lost activity that actually we did do this work back in 2020, and yet I was pleased to say that we'd awarded a contract in Somerset. However, since that time, the provider that was awarded that contract has had significant challenges in finding a suitable property. So we've been linking in with the ICB and hopefully council as well to sort of say, look, actually, where could we find a good premises for this provider to go? So the contract is still there. There is still a willingness. There is still an ability for them to be able to deliver. They just need the premises to be able to deliver that from. And I think it was around the Wellington region was where the contract is based, and it was within a short radius, a small radius of the Wellington area, that a property would be deemed desirable. They had found a suitable premises, but that was to actually withdrawn at the time of the contract award, which was such a shame. So it's still there. There's still a willingness. If we can all come together and find a place to put this practice, then we can get that up and running.
Excellent. And we have sat with the local authority as well, with the request as well. So anyone got any links? Let us know.
Well, certainly worth some. Can I last get that? Can I go to Councillor Oakes, please, our last speaker? Thank you.
Thank you, Chair, and my apologies for not being with you today. The joy of running a care home is that sometimes staffing can become acute, and it's a bit of a challenge, but we've got past that and all good here. Onto dentistry. Can I just say, from the point of view, my opinion is the NHS at the moment is in total failure as regards dentistry. I speak as a man who is 63 years old and has enjoyed the NHS for 62 years as a patient, and not anymore. Having waited at a dentist, an NHS dentist, for a year to have some non-urgent treatment, as I was then told, oh, we're not NHS anymore. And also in a situation where one of my colleagues who came from the Ukraine because of the war has returned to the Ukraine because she can get dental treatment easily rather than in Somerset. So there's something a little bit wrong with the situation where that occurs. My 2 points I want to say, I like the idea. Sorry about that. That's very noisy. I like the idea.
Could you have a question, Councillor Oakes? Could you just give us a question?
Okay, the question is, and I look forward to sort of the masterclass, but on the element of how people are rewarded, let's see if I can. Yeah, let's look at that. How people dentists are rewarded and the UDAs and everything else is an element of the contract, a kind of retainer. In other words, that there's one element you get paid because you've got 50 patients, you get 50 units of payment each month, might be 3p, I don't know what the numbers would be, but a retainer element was that part of the contract, or was it purely on performance? I wanted to check that my dentist was not being paid for refusing to treat me basically for a year.
No, there's no retainer. There's no retainer, no capitation payments at all. It's purely based on the number of UDAs within a contract and their ability to be able to deliver those UDAs. So that's it, but we can cover it all in the masterclass. But no, you please be assured your dentist would not be on a retainer for capitation payments and not treat you.
But it might explain why my dentist back in the 1960s was so keen to drill holes in my teeth. If that's what it was paid
Yeah,
for.
yeah. So prior to 2006, they were paid by results. So it was essentially done as a, they got paid for what they did, which is slightly different than what happens now. But we can cover that in the
I'm really looking
masterclass.
forward to this masterclass. I think that we'll get a better understanding, but also maybe have some ideas of yours. And I have noticed the one about the business rates one. As long as it's for NHS only surgeries, I would certainly support that if we look at that as a council. I think anything that expands the number of NHS dentists is something we have to seriously consider. So thank you very much for that.
Thank you, Councillor Oakes. Thank you. Okay, I think we've really done well today. Thank you very much. As you can tell, this is a really emotive and it's a really interesting subject. And we look forward, there is a joint scrutiny on the 25th of October. And I would say to everybody, it's being held in Taunton Deane. And I would say to everybody to come along, because I think it's something that we can talk about for hours and hours and hours. So, and I thank all of our speakers today. We try to keep it down to time because obviously there is another workshop after this that a lot of people are missing, but that's unfortunate. But thank you very much. What I would like to say is I think the masterclass, and I think further, we can even do it on Teams so that we can get as many there as possible, or if not, if you want to come here, whatever. But I think it is absolutely needed. I think we do need to know, because there's a lot of assumptions being said today, a lot of informed information that we're getting or picking up, and it's not correct. And you are the people that can perhaps sort it out, tell us the truth, what's happening, and that will make a lot of difference.
And I'm just wondering if it would be worth doing that with pharmacy as well. So if we did dental followed by pharmacy.
Wonderful.
Would that be?
I can talk to you for 3 hours on it, so don't worry.
Because that's my other hot topic.
Oh, I'm so pleased. I'm so pleased. I just want to let you know that now we've got you both. You're not going anywhere, okay? We're just going to keep a link to you all the time because it is it's a hot topic, really hot. Thank you very much for the day. Thank you for answering all the questions. Thank you also to Tessa and Matt online, and another lady. I'm sorry if I've missed anyone, but thank you so much. And thank you so much for the councillors online. With this part of the meeting now is formally closed, okay? We're going to have a 5-minute break and then we're going to go into the workshop because we have to finish the meeting at 1 o'clock. So 5-minute break. Thank you, but